We're going to talk a bit today about trauma-informed practice. In terms of disclosures, this is who I work with or work for. In terms of grants, research support, honoraria, consulting fees, all related to the BC-CfE or VCH. There are no medication names in this presentation. I have no biases to declare. So let's start off by talking about what trauma-informed practice is. One of the definitions is that it's an awareness of the prevalence of trauma, so just the idea that we know trauma exists. It's an understanding of the impact of trauma on physical, emotional, mental health, as well as behaviors and engagement to services. And it's an understanding that the current service system can re-traumatize individuals. One of the things that I had a bit of a tough time wrapping my head around initially when I first heard about trauma-informed practice was what's the difference between trauma services and a trauma-informed practice? And really, trauma-specific services are programs or interventions, therapeutic services aimed at actually treating the symptoms or conditions resulting from traumatizing events. And trauma-informed care is an approach based on the knowledge that the impact of trauma aimed at ensuring environments and services are welcoming and engaging for service recipients and staff. So to really get an understanding of what trauma-informed practice is, we should have a basic understanding of what trauma is. And trauma, simply put, is an experience that overwhelms an individual's capacity to cope. It can be both internal and external, and that the resources available to individuals are inadequate to cope with the external threat. And they're life events that are outside of an individual's control with potentially devastating emotional, physical, and behavioral consequences. So this is a quote that I think really just sums up the presentation today, in that trauma experiences are inherently complex and present in those exposed to them, a wide range of reactions that affect all aspects of their lives. Therefore, it is essential to create systems of care that respond to the complexity and diversity of trauma experienced in the lives of those whom practitioners in the helping profession serve in the context of various systems and agencies of service delivery. So to summarize that quote, it's complex, trauma is complex, our systems are complex. Let's talk about the types of trauma. So there's single incident trauma, unexpected or overwhelming events, complex or repetitive trauma, and I think this is where most of us go to when we think about trauma in our patient population, so ongoing abuse, domestic violence, or war. Developmental trauma occurs during infancy, childhood, or adolescence, includes physical, sexual, emotional abuse, and neglect. And then something that I'm actually starting to think about a little bit more on a regular basis and include in my kind of construct of what trauma-informed practice might look like is the idea of historical trauma. And this is massive group trauma causing emotional wounding over the lifespan and across generations. So this idea of intergenerational trauma, and we see that in cases of genocide, colonialism, slavery, war. And how do we decide if a program or organization or your clinics are trauma-informed? The idea is to realize that the widespread impact of trauma, that there is widespread impact of trauma, and understand the potential paths for recovery around that. It's recognizing the signs and symptoms of trauma in clients, family, staff, and others involved with the system, and responding by fully integrating knowledge about trauma into policies, procedures, and practices. So really being thoughtful and intention-based on, okay, we've acknowledged that it's there, how is our clinic or organization going to address it? And really looking at actively ensuring and resisting re-traumatization. Well, that didn't show up the way it's meant to. So principles of trauma-informed care, and you guys will come across these lists. I think if you Google trauma-informed care over and over again, it kind of talks about 4 points, and there's a bit of overlap on this computer for some reason, but the first is really just trauma awareness, being aware that trauma exists. The second being safety, so creating a space that's safe for the patients and for the clinicians that are in that space. The third in this one, because there's 4, the third is choice and empowerment. In some of the definitions or the algorithms that you'll find, they'll actually separate these two. But I like them together because I think choice really creates empowerment. And the last one being, it's a system of being strengths-based. So looking at individuals and looking at their strengths and using those strengths to speak to how to manage those situations or how to better navigate those situations. So let's move along to the idea of acknowledging or having an awareness of trauma. So this is St. Paul's Hospital, and I'll tell you what St. Paul's Hospital means to me. I did my MSI years, or my medical student internship years, at St. Paul's Hospital. And it's where I fell in love with medicine. I had great preceptors. I started off there in internal medicine. I had these teachers that loved medicine. They loved exploration. They loved teaching. It was where all of the different pieces of first and second year really came together for me. I loved the windows. I loved the architecture. I loved that the stairs were a little bit crooked. I even liked the odd pink paint in one of the stairwells. Because for me, St. Paul's Hospital was where I became a doctor, right? So it was only good. So this is a picture of St. Paul's Hospital in 1923. And you know what, I still actually feel that way every time I walk into St. Paul's, because I still work there. So this is St. Paul's Hospital in 1923. Do you guys know what this is? It's a residential school. It looks a lot like this. This is a hospital. This is the Grey Nuns Hospital in Regina, Saskatchewan. This is a residential school. So it was only a few years ago that a patient of mine told me, he said, I hate going to St. Paul's Hospital. And in my head, I kind of went, but we're so good there. We're really good. I don't know why wouldn't you like it? And he said to me, my mom was in a residential school and she showed me a picture of what her school looked like. And it looks exactly like St. Paul's Hospital. So it's really hard for me to be in there. And immediately it crystallized, like this was an individual who repeatedly left against medical advice. And it all made sense. So just physically entering that space was re-traumatizing for this individual. So recognizing that the exact same space can mean different things to different people. And also recognizing that this didn't happen to people's moms and grandmas and great-grandparents. The last residential school operated by the Canadian government in Saskatchewan was closed in 1996. I was in grade 11 in 1996. So that's really today, right? So something to think about. Another thing that I got asked to speak about is the ACE study, or Adverse Childhood Experiences Study. Who in the audience has heard of this before or has had some kind of awareness? Everyone, yeah, that's what I thought. So really the ACE study findings looking at certain experiences and exposures, and from that they realized that it increases your risk of other disease processes or events. So really this is a questionnaire that looks at different types of abuse, physical, emotional, sexual, elements of neglect, including physical and emotional, and then household dysfunction, things like mental illness, incarcerated relatives, a mother who was treated violently in your presence, substance use, or divorce. And the study says, or has demonstrated, that as the number of ACEs, or adverse childhood experiences, increases, so does the risk for negative health outcomes. Does this show up? Yeah. And it doesn't, we in our line of work, we often hear about it in terms of substance use, that it increases your risk for developing a substance use disorder. But it is really important that for us to know that it increases your risks of many other things, physical disorders, chronic diseases, in addition to substance use disorders. But if you look, there are things like cancer and stroke on that list as well. Here's how I really feel about the ACE score. Actually, I'm not going to stand up here and tell you how I really feel. We can talk about that later. But here's the part that I want you guys to remember when you start thinking about the ACE score. So the ACE score is not a crystal ball. It is not going to tell you that this individual for sure is going to have a substance use disorder. And I think these are really important things to consider when you're considering pain management, or when you're looking at whether a patient should or should not be parenting. So being very careful about understanding what the ACE score is telling you. It's also really important to know that it's a one-sided equation, that it doesn't actually have an ability to tally or factor in positive experiences in early life. So the stabilizing presence of grandparents would be a good example. And that there are certain things that can help build resilience and protect children from the effects of trauma. I don't know if you guys have come across this, but I'm getting a lot of push or encouragement to use the ACE score in certain settings. And I would just encourage you, if you are going to do that, to sit down and actually look at that questionnaire and consider what it might be like to have to answer those questions, and consider when it may be appropriate and when it may not be appropriate to engage in that questionnaire. And I think the most important thing in trauma-informed practice is that being trauma-informed as a clinician doesn't mean you're actually informed of your patient's specific trauma. What it does is this, though. Being trauma-informed at its core is a model that replaces the labeling of clients or patients as being sick, resistant, or uncooperative with the idea of being affected by an injury. And that viewing trauma as an injury shifts the conversation from asking, what is wrong with you, to what has happened to you. And I would argue that it actually makes our jobs a little bit easier. So early on in my career, when I would interact with, the patient that tells you to F off the minute you walk into the room, that made me really sad, that when that would happen to me, and invariably it happens. And my inner dialogue would be, I'm just trying to help. Can't you see that? I'm just trying to help. And when I started to wrap my head around the idea of trauma-informed practice, it's actually quite freeing, because you realize it's not about me. It has nothing to do with me. It's about the collective experiences of this patient, and potentially when it does involve you is what you represent. Because you represent, with your stethoscope around or in my case, stethoscope around my neck, I represent every physician or every medical professional that said to an individual, I think you're drug seeking, or you don't deserve care, or I don't believe you. So that's what I represent. And so my mantra in my practice is actually, it's not about me, which is quite lovely. And then one of my favorite things to talk about is the idea of language and how it can perpetuate stigma. And that stigma is one of the biggest barriers to treatment and recovery for substance use disorders. And ideas around using language like abuser or drug habit, addict, drug user, these are morality-based. This is morality-based language that implies choice. It implies the idea of good versus bad. And what your patients are hearing when you use language like this is that it's your fault, you've made a choice, there's really no hope, and you're probably a criminal. And the idea that you can be very intentioned and very powerful with the language that you choose. So using languages that aren't language that isn't labeling, stuff like this is an individual with a substance use disorder, describing the disease process. So we talk a lot about how substance use disorders are a chronic disease, and looking at using words like regular or remission, long-term recovery would be another one. I think we hear a lot of language around clean or dirty, and we don't need to use that language because medically clean and dirty doesn't actually mean anything, right? Like medically it's negative for substances tested or positive for substances tested. So recognizing that language creates an environment, and if we're trying to create a trauma-informed environment, being mindful of the language that we use and the language that we perpetuate is going to play a big role. In 2018, there was a trauma-informed practice guideline that was actually released with specific focus on the opiate crisis. And it's got really great chapters on the opiate crisis in general, but for anybody who does any kind of perinatal or women's health work in substance use disorders, it's got some really, really great and helpful chapters in there. It's also important to recognize that trauma-informed services there's no cookie cutter approach, that it's going to look different depending on the service setting and the organization, but there are some common themes. So things like providing welcoming spaces, walk into your clinics and pretend you're a patient or a client or what have you. And one of the first things I notice in health authority-based offices is we have a lot of plexiglass. And I think the messaging there is you are potentially dangerous. And that's one of the first messages our patients are getting. So it may not be something we can change in some of our clinic settings, but it is important to have that awareness, and perhaps if we can't change it, how do we counterbalance it? Offer choice, voice, and control to all patients and clients accessing services. These spaces should work to create a physical, emotional, and culturally safe environment for everyone, including the staff. Opportunities to learn wellness skills and coping skills for managing trauma responses. And provide information about the effects of trauma and resources for learning more about trauma or how to access trauma treatment in the community. In these spaces, identify and work with people's strengths rather than focusing on deficits and quote-unquote difficult behavior.